while we get the slides, I can introduce myself. So I have been supporting the organization of this event, which I'm really happy. And yeah, I'm a biomedical engineer. I will talk about what has been our contribution during the COVID, taking the view of the World Health Organization, because it happened that I am the innovation manager for COVID technology for the World Health Organization. And after a few years in the UK, I would say about 13 years, I'm back in Italy to the University Campus Biomedica in Rome, where I am creating a new lab where this kind of activity will remain a core topic for my lab. As soon as we get the slides, I can be more specific than that. Meanwhile, let's make an experiment. Can you raise your right arm? Can you please? Cool, so it works. So if I ask you questions, you can, okay, fair enough. Okay, so that's me. So I'm in a transition from Warwick to Rome. So you see both affiliation here, but probably most important for this particular talk is my hat of innovation manager for the World Health Organization for COVID technology. And by the way, I'm the president of the European Society of Biomedical Engineering and Secretary General of the World Society of Biomedical Engineering. And that's important because this means that those international societies are very sensitive to this particular area of research. I will come back on this later. And we have here Yari, and we'll have the president of the International Society to grant you the awards. So, a few slides about myself and my research activity. Well, I spent all my life working on medical devices, looking at this from different perspectives. So from design to the assessment to regulatory science. And then I spent a lot of time in health technology assessment because I really think it's important to understand the needs of users, sustainability of a medical device, can we afford it, why we now call trust an hospital, which was not a trust before because there are no profit trusts. So, but still, you need to be sustainable. Otherwise, the alternative is that you will have no money to get hospital in future. So you need to put responsibility also on hospitals. I've done several things. My other area of work is artificial intelligence. And you will see with Katie's talk an application of AI for low-income countries. But we do mostly AI for also high-income countries. If you come visiting our lab in the UK, you will find those kind of devices as in many other lab, but most important, you will find those amazing people. If I can ask you to stand, many of them are here. Katie Stoke, Wenzi, and Abdulaziz, Owen, Busola, and out for lunch, thank you guys. Davide, Alessia, and Silvio, which are here. What I really like of this slide is to stress the fact that this is a multidisciplinary setting, because as biomedical engineers, we work on complex problems, and there is only one way to do that. Have multidisciplinary approach. So Alessia is a bioethicist, Wenzi, Salman are computer scientists, Tim is a mathematician, Carlo is an health economist. So we are really a multidisciplinary team, and that's what you have to learn. So you will work in multidisciplinary environment where you cannot think that technical work is more important than regulatory science or the other way around. So you need to be aware of the fact that if you really want to get an impact, you have to take all those dimensions into account. And just because you are engineers, this does not mean that economic aspects, regulatory things are less important. If you don't want to have an impact, fine. You can do philosophy, abstract or theoretical physics, great. Engineers, we are here to have an impact. To have an impact, you need to learn also those dimensions. Otherwise, your work is useless. And that's the new team in Rome. So for now, it's just Anna. She started in September. Few PhD scholarship. You are all PhD, so you don't need. But if you are towards the end of your PhD, I'm going to open a position, very well paid, I must say, on AI for different things. So if anyone is looking and does not know what you want to do next, come to me and we may have a chat about that. Now, starting from that, as I mentioned, we have a lot of experience and we did several field studies before COVID. After COVID, we have not yet restarted. We have in our team scholars and friends from lower income countries. We mainly focused on Africa, but this is not the only place for low income countries. And our perspective is that we know exactly how a medical device works in relation to people, doctors, patients. What we know much less is how medical device works in the context. So how the context affects the work of medical device or not, safety, efficacy, and other things. And that's really what changed in Africa. People are the same, but the environment in which you do care is completely different. And that's what you need to focus on, as you have heard also in the previous presentation from Filippa. We look at this problem from different dimensions: design, regulation, management, assessment. And that's just because if you look into only one of those, you have no impact. And we are fan of impact, we are fanatic of impact. And so we want to have impact. So together with technology, together with science, you need to take care of the other domain. Otherwise, there is no way you can succeed. Oh, and that's me. In Africa, we started with work on maintenance of different things, and then we moved more into innovation. But today, I will not talk about that. So I will not talk about our work. You will see something from Katie's talk, but you can read our papers, and if you have time, we may have a chat along this week. What I will be discussing today, well, that's an example of our work, but again, it's just not for today. I want to focus your attention on this slide. So this is the global ecosystem of biomedical engineering. So we are, GNB is the National Society of Biomedical Engineering. We are member of the European Society, IAMBES, which is the European branch of the International Federation of Biomedical Engineering. Together with medical physicists, we are joined into IUPES. This is an overarching scientific society which puts together biomedical engineers and medical physicists, which in many countries, they are much closer than we are in Italy. In the UK, there is only one society merging both, same in many other countries. Why this is important? Because those scientific societies are also NGO in official relation with United Nations. So we work daily with the World Health Organization, with UNESCO, with the International Agency for Nuclear Power, and many other United Nations agencies, because if they need technical support, if they need scientific advice, they normally come to scientific societies in official relation in order to get input. And that's the way to enter in this domain. And then many of us, you may spin out and getting more and more responsibility in those agencies. Now, the chapter you find in the book you have been given is all about what has been our contribution in this particular moment, so during the pandemic. And the introduction starts from this series of events. I don't pretend you to have already been through that. I mean, you were given the book this morning, probably the electronic version a few days ago, but doesn't matter. So everything started in December 19, when WHO was informed of an unusual SARS syndrome of respiratory system. And this triggered a lot of attention, especially because in January, suddenly cases were reported also from the USA, from China, when everything was reported, to USA in only 1 month. And the characteristic of SARS triggered really the attention of the global scientific society. Therefore, at the end of January, the World Health Organization defined the public emergency of international concern. So they started telling to the world, hey guys, there is an issue here. And this is a binding act. If you are a member of United Nations, you have to react. Even just saying, I don't care. But if you are a member of United Nations, as a state, as a government, you have to take act of that. So when there is an emergency of public concern, this is a legally binding act. It's not just an ancillary document. And then we arrived on February when the first cases were reported in Europe, actually in Italy, actually not far from here. And the name SARS-CoV-2 was officially granted, which means this was introduced into the global taxonomy of viruses. Before that, it was isolated, and in the book you will find my comments on that. It was a great job. I mean, colleagues from China did an amazing work. I mean, isolating a new virus and understanding it's a new virus out of few tens of cases during the the main celebration of the year, which is the Chinese New Year, is as if we say that in London, you can understand there is a new disease out of what? In proportion, this was few tens of people in a town of 12 million. In Europe, it means 3-4 patients in Milan during Ferragosto. It's impossible, no? So we have to acknowledge the fact that the work done by Chinese colleague was amazing, instead of putting on them the blame that was put on them in the very start of the pandemic. And so things escalated a little bit. We arrived towards the end of February when there was this emergency call for the Global Forum of Research and Innovation for COVID, done in the framework of the Blueprint Agenda, which is a wider agenda putting together research, innovation, and policymakers at the World Health Organization. This was triggered years ago from the Ebola outbreak, but now this is a system which is in place and it works. And this time was activated towards COVID. And the most important, at the end of February, we published the Research and Innovation Blueprint and COVID Agenda, which was the document which initiated globally all the research and innovation for COVID. And guess what? In March, then, the World Health Organization escalated from emergency or public concern to pandemic. This may mean nothing to you, but it is not nothing, because now it means that the Ministry of Health has to respond as a matter of priority to this emergency. So this is really kind of, call of duty. So now it's legally binding. You cannot ignore us. You have to act. You have to interact among yourself with us, and we need to do something. Well, what they did. First thing in Europe, they published this recommendation. References are in the chapter, where for the very first time, the European Commission gave a waiver to the European regulatory framework for medical device and personal protective equipment. So the first action is, okay, our regulation is no more binding. Do more than you can do in our regulation. We'll come back on this comment later. An important act, it's an historical moment. And just to give you the time scale, then everything was triggered then, and then there were 8 priority areas of research, then 5 were added. One obviously was about vaccination. And just to give you the time scale, so only in May we published the criteria for prioritization of vaccines for COVID. And in August, we published the first document on the state of the art of the global observational studies on vaccine safety and effectiveness. And in December, we got the first vaccine approved by EMA, which is the European Agency for Drugs and Vaccines. It's only 7 months. So this is the first time in human history that we get a new disease discovered, criteria defined, and a new vaccine out on the market in 7 months. So this is a gigantic accomplishment for human being. That's more important than having been on the moon. On the moon, we took a while. And we are trying to go back and still we struggle. This is the first time we managed to do that in 7 months with a completely different technology, by the way, which was there developed for WHO work for Ebola, but that's another story. And where do we fit in the story? Well, first thing we did as biomedical engineers, as IFMB, we keep working with the World Health Organization, and our main contribution was here into the definition of essential list of medical devices and PPE. So what it is essential, what do we need? Ventilators, masks, and other stuff like that. We got a lot of support from our colleagues from Asia because they practiced it with SARS, MERS, and the other epidemics they had in the past 10 years, which was great experience. And again, from triggering of the working group, which in this case were just changed of function, to the definition of the first documents on medical devices, which why are important? Because the European recommendation told to manufacturers and innovators, well, you will never be able to use ISO unified norms because they require time. Please consider using also World Health Organization technical documents because they are good. This was the first time in the history of the European Commission. And then we started working also for the emergency program. That's where I sit now. And apart from medical device, we started working on personal protective equipment. And in March, we published the first document. So rational use of PPE in the context of pandemic and severe shortage. So things such as reuse of PPE, local manufacturing were completely novel, but in a time which has never seen before, has put together the best possible evidence in order to write technical guidance. Because this is not based on our opinion. This is based on science, rocket science, the best possible. Science requires time, so you have to admit that in the short run, you may need to do more in order to get better evidence than that. And so my few, the lesson I learned in this experience was that the World Health Organization contribution and United Nations ones, we have here UNICEF, which is working, and many other agencies, is amazing, is astonishing. So first of all, to identify the priority. What it is the first thing we have to do in case of pandemic or disaster. And then to provide guidance and harmonization. So we tend to underestimate, but if you wake up tomorrow and you want to do a protocol for assessing a virus, well, you don't have a library of protocols unless you use the World Health Organization once. On scientific papers, on journals, you can find whatever, but come on, we have, very much aligned view, and yet we fight among ourselves on how we see things. So you need a reference protocol. Doesn't matter if it is not perfect, but it's the best possible, and you need a reference so that if you do this study in 10 different countries, you get similar results. Science is science only if you can replicate. So having the protocols is crucial, and this has been the main effort done in the first 3 months. Peer reviewing, evidence, the best possible. We didn't have time to run usual trials for everything because simply it takes time. We did our best. There was an acceleration in time to get an ethical approval for priority. All the ethical committees prioritized only COVID-related studies. There was a huge effort globally triggered by the WHO. Yet, there were no technical times to get randomized control trials. So for the very first time, we used the real-world data in order to assess the safety and the effectiveness of vaccine. And this will stay also methodological speaking. And come on, we didn't did. The results were brilliant, by the way. Most important message for our community. Well, first of all, this is an institutional framework. It's not just, we like to meet on Friday evening and play Dungeons and Dragons. No, this is the institutional framework. This is where the main guidance and the binding links comes for the world, not just for this country, this region, or that region, but for the world. And anything happening outside this context is very unlikely that will have an impact in the short term. It will have, and it's probably much better than the work WHO can do, but it's impossible to have the same impact and to scale at the required level in such an unprecedented short time. So those are the key points that triggered my attention. And obviously, working independently from this framework, ignoring the priorities triggered by the World Health Organization means to create a lot of white noise, what the United Nations defined the info pandemic. So suddenly journals were bombarded with papers such as, wait, let's see how can I do a mask with foil for oven or stuff like that, which I'm not saying it's trivial, but if it is outside of this framework, it's creating more white noise than solution. And I can come back on this comment later if you like. So this is the document we published. That's actually the latest version. This is from February this year, where you can find now the priority areas, the priority criteria. That's the entry point. You can enter here and you get reference to all the other documents. Everything is referenced into the chapter. And particularly relevant for us, biomedical engineers, we produce medical devices. Whatever else is science, fine. But our impact is medical device, as Carmelo correctly defined it this morning. And that's a story which lasts longer than COVID and comes from before COVID. So together with the World Health Organization, we have been since ever working on the priority list of medical device, human resources for medical device, nomenclature, procurement, country support, policy resolution, and continuous monitoring and survey, which is not easy. And in fact, this effort resulted in the World Health Organization Medical Device Technical Series. If you ask me, I don't like those books. As an academician, I prefer our books, no? But those are not meant for academicians. Those are technical guidance, because if in Ghana, you are creating a new hospital, you need the list of essential medical device. And if you read this series, you will find, I don't know, the list of essential medical device for cancer, cardiovascular disease, and many other things. From the perspective of Europe, they're not adequate, or list of essential medical device. But something we struggle thinking is that Europe is a minority. we tend to think in our comfort zone that Busola is a minority, no? Because we don't have yet enough African scholars in Italy. But it's the other way around. In Europe, we have less than 10% of the global population. Europe, USA, Japan, so let's say the 3 most advanced economy or the 7 most advanced economy, they get to more than 30% of global population. So as a matter of fact, we are a minority and we struggle understanding that we remain a minority in this context. So when we read those books, we have to think about the wide majority of the global population, which find those guidance very useful. And our paper, much less. So that's a matter of fact. Compendium of Innovative Medical Devices. That's probably the one that you may like more. This is a collection published each other year, more or less, where there is a lot of work in order to highlight those innovations which is suitable for lower income countries. The reason why I like it very much the last one we published, which obviously it's significantly focused on COVID, although not only, is that for the very first time, we managed to have a very robust method for assessing things which were proposed to the WHO, which, as you can see here, start from the regulatory assessment. So if everything is fine, the recommendation is to proceed. But if something is missing, such as this innovation doesn't have yet CE marking or FDA approval, then you get a warning. It's good, but it does not get any regulatory approval. Otherwise, it's not acceptable or not applicable. And same for other things, health technology assessment, clinical evidence, health technology management, what we call clinical engineering, IP, intellectual property, and capability to manufacture this device locally, or spare parts. That's essential. The wide majority of medical devices which I've seen in Africa, which were not working because of the lack of spare parts and consumables. We get donation, we don't ask even ourselves if they have this. And obviously, make clear the context. Is it primary, secondary, tertiary level? Is it for ambulance, rural areas, indoor, outdoor? That's something that when you will have to work on your project since this evening, we pretend you to focus on that. I mean, you have to be sharp enough to tell us, look, I want to just do an increment. I don't want to change the world. I want to increase incrementally health and whatever it is the problem I want to target. Doesn't matter, as far as you can position your contribution in the wider picture. So if you tell me that's just for outdoor, don't use it indoor, that's fine. But if you don't tell me if it is for indoor, outdoor, probably because you didn't even think about that, that's an issue. You are creating white noise and not innovation. That's a problem. Now, if you spend a few seconds reading this sentence, doctors were unable to cope since they were threatened by the disease, or treating the disease for the first time and in ignorance. And more important, the more they were treating patients, the more they were dying for this unknown disease. And in the end, people were overwhelmed with this disaster. And I shall give a statement of what it was like, which people can study in case it should ever happen again. Okay, let's make a game. When do you think this statement was written? Who does think this was written this year? Can you raise your hand? 2 years ago? 5 years ago? 10 years ago? 100 years ago? 1,000 years ago? So the other which have not raised their hand means they don't think this was written? Anyone has a different opinion? When do you think this was written? How many years ago? Can you guess? 50? Who offer more? This was written 2,500 years ago. So this is Thucydides, something like that, which was an historian from Athens. This is the description of the plague in Athens. So this is 2,600 years ago, 500 before Christ, yet we don't know how to cope with pandemics. And this last recommendation is astonishing. I need to gild this statement because people in future can study and find themselves prepared. We don't read enough, that's clear, no? So, disasters, pandemics are not novel to human beings, but what do what can we do? We can work on preparedness. And what do we mean by preparedness if we sit at the United Nations? Well, we make an effort in order to forecast and taking precautions so that we can face things before they happen or before it is too late. And we focus, when it comes to preparedness, on 3 stages. Prepare yourself, react as soon as possible, as effectively as possible, without generating other problems. Otherwise, you fall into the info pandemic. And third, restore. So we have to go back on normal life as soon as possible. Those are the 3 phases we have in mind when we think about emergency. And for the emergency program, this has few more specification. Again, this is in the book. You are smart guys. You don't need me to comment on that. But you need to adopt this mentality. Otherwise, you will never be able to give a significant contribution in this field. And all the below is based on the CDC hierarchy of risk control. And so I felt appropriate to spend a couple of pages in my book describing this work, which is trivial once you read it. So the hierarchy say that there are different things which they are of growing effectiveness, which start from elimination, remove the cause for treating it. Fine. How do you do that? Sterilizing vaccines. So a vaccine which can destroy the virus and help you not to get the disease again. We tried hard, we failed. Fine. We ended up with the vaccine which is not harmful and very effective in reducing the consequences of the disease. Well, it's not exactly what we had in mind, but, still a great result. And other things you can do meanwhile, well, for instance, create COVID-free hospitals. That's why you were not allowed to enter an hospital to visit a patient, because it was more important to protect hospital from the disease than anything else. If you cannot eliminate, which is exactly what happened to us, you have to substitute. Substitute means if you have a choice, you choose the less risky procedure. For instance, minimal invasive surgery was discontinued during COVID because it's an aerosol generating procedure. You have to inflate the belly, and this may generate aerosol, and this was risky for the diffusion. So we prefer to go back on open surgery versus minimal invasive surgery in order to keep proceeding with surgeries. Otherwise, the alternative was to stop surgery. So we know minimal invasive surgery is better than open in many kind of applications, yet during COVID, it was not possible. Still, you don't manage to solve the problem with substitution. And if you don't, you have to go next. Engineering, and in the book you find my opinion, engineering is just seen as a little part of the global picture, and that's our fault. We never worked enough on those problems. So we should position engineering much better than it is now. We got the 3rd place. Come on, it's still good, but it's not the 1st. So we really need to ask ourselves, what else can we do? Engineering means, changing the air conditioning, filtering, inverted pressure, and the things that you can do in an hospital. And that for the first time, we're moved also to real life, so outside the hospital, by enforcing regulation for number of people in this room. We were not sure about the number of attendees we could have had in person because we didn't know. And enforcing other measures in order to contain risk in real settings. The last 2 steps are administrative controls, changing the way we work in order to reduce or minimize the exposition to the virus. And last step is personal protective equipment. Once again, all this noise in television about this is the less effective thing. That's when you are accepting the risk. So you are accepting the fact that you cannot do the other things. And now, guess what? Wear mask, better than nothing. So that's exactly where we position PPE in the context. If you don't know this logic, you struggle understanding the recommendation of the WHO. You struggle understanding where innovation is needed. Innovation is needed on PPE because I think they can be far more important. They are not there because they are still the same as 700 years ago. And probably the most important thing here was the introduction of community masks. So masks, they can be personal protective equipment or medical devices. For the very first time, we have now technical guidance for community masks, the ones made of different materials and also locally manufactured. This is a significant change, but doesn't really matter now. The problem was that in the start of this pandemic, what happened was that even national government, they were instigating naive innovation. For instance, I just took USA and UK government, which started supporting local manufacturer or whatever, asking them to start entering the medical device PPE domain. This was a catastrophic disaster. In Spain, we had SEAT. In France, I don't even remember. In the UK, Dyson. And as a matter of fact, none of those ventilators was really used. So this has been a catastrophic failure. We spent millions of pounds, euro. We spent time. We gave money to the wrong people. And this resulted in no one medical ventilator introduced into the market. Not from SEAT, not from France, I don't remember the manufacturer, not from Dyson UK. This all was an effort of several million of euro. The only positive experience, sorry to say, it was from Italy. In Italy, the national government didn't ask to Fiat to manufacture ventilators, but they went to the Italian manufacturer of ventilators, sat to the table and asked them, hey guys, what do you need to increase your production? And they told them, look, microchip, we need valves, and we need more trained engineers. And they say, well, we can call Fiat, Ferrari, whoever else, to produce this tiny bit that you struggle because normally you buy from China and now China is closing boundary. And we can give you some engineers from army. They are super trained, hyper qualified, that they can work 20 hours per day. And this worked. I mean, from 10 pieces per month, they escalated to more than 200. So this was a fantastic story, which still has not been talked enough. I mean, I still have to use newspaper references. I probably wrote a couple of papers on that, but it's not yet a consolidated good practice, which actually should be. I was mentioning before innovation. So just took ventilators because it was so important for COVID. And if you think about how this changed in hundreds of years, this was a ventilator more than 100 years ago, and this is how a modern ventilator looks like. And you compare with mask, well, I must say that in the last 700 years, we didn't make much progress this year. So sometimes the problem is that we don't really invest in innovation where it is needed. If I ask you to do a PhD on a mask, probably you would tell me to go fishing, which I love. I don't like fishing. But the point is that you have to do what it is needed, not just what you like. And that's another huge and important message I want to give. There are priorities, and you need to balance your interests with global priorities. Otherwise, again, impact is far. Few numbers on the shortage, but you know the story, but you will find it in the paper. Again, wild innovation. I understand that it was moved by the best possible effort, but if Dyson failed, how can we succeed in a make-it-yourself lab? I mean, there have been great stories. I myself encouraged a couple in local hospitals where things were really getting wild. So with 3D printing and the help of the international community, they managed to produce valves and other stuff like that. But the wide majority of those things ended in nothing, which would be still fine, but was even harmful because, you know, there was no control and no check of that. So my conclusions are here, but again, we should focus on what it is needed, possibly aligning the needs with the international guidance, because trust me, it works. So this pandemic is supporting my hypothesis. It works. We have several papers in this field. There is a chapter in the book which is relevant because it's all about the inadequacy of regulatory frameworks in time of emergency and in general for lower income countries. What happened there is that you get surrounding countries, Africa in particular, which they adopt CE marking as their reference, ignoring the fact that this is not designed for them. So what it is safe in Europe, because the CE market could well not be safe in Africa, not to mention effectiveness is important, but safety is more important. So if you deepen this paper and you will find the reasons in the book, our framework, regulatory frameworks are completely inadequate for low-income countries, and yet they adopt our regulatory frameworks without having enough critical approach. So the other way around should be to bring African scholars when we sit and write European regulations, because we know that they are adopted also by them, and it would be really useful to get some insight into the real needs of other countries using our regulation because they lack of a strong regulatory framework. Now, towards the conclusion, there are a couple of other things, but you can read it. I want to just move to the final points and just give you my few thoughts. So first of all, there is a huge need of more and well-trained biomedical engineers. It's not me, it's the World Health Organization which is asking for that. International stakeholders are eager to get support from you guys as far as you understand what are the real needs. So if you arrive there to satisfy your ego, no, that's not the approach. But if you know what they need and you are there to serve those institutions, that's a wonderful approach and very rewarding experience. We have to better understand the needs and view of international stakeholders. As I commented, we are a minority and we still struggle digesting this concept. Our income countries are a minority on the globe. And the global health perspective is different than the one we have in Europe. Does it mean that I don't trust those international organizations? No, I trust them, but I do my best to bring there people from the global world, so from those countries where the majority of global population lives, and not just as a tick box exercise. We see them on the table, we train them, we put them in the position to give valuable contribution. That's the only constructive approach. Criticizing United Nations because they don't work yet perfectly, it's another approach, but it's good for Friday evening drinking a pint. But if you want to be serious and constructive, that's the solution. Bring to the United Nations, to the World Bank, people from the field and try to support them, telling them what are the priorities, because very often decision makers there have never been in those countries, and very often they do not understand that they are just a minority. So those are important points to me. Ethics is not an embellishment. The only solution we had when regulatory frameworks failed was ethics. So there is not a written code to tell you how to act during an emergency or in rural areas, in remote areas in Africa. Often there is not. So the only thing you can rely on is ethics. And ethics is not an abstract concept, but is a kind of something you can face as a risk management approach. I can elaborate on that later if you like. And most important, it's the conclusion in many of our papers and in the chapter, we need certainly responsible action, responsible thinking. Sometimes we need responsible silence, because it's important to give the word to those which have more information and experience than us. Carmelo, I hope I was in time. I didn't look to my, probably I was even too quick. Fine, so now. Questions, comments? Don't be shy, let's try again. Can you raise your hand? You can.
Just as a comment on the example you gave.
We need a microphone for people attending remotely.
About the mask, so simple and so important. I'm thinking about washing hands. Is the other action, which is really forgotten and undervalued, and instead is one of the major way to combat safety. I mean, to
it's not forgotten. Allow me to integrate this comment. We did 2 observational studies on global scale. What it was missing there was evidence. So we designed 2 cohort studies in order to provide the best possible evidence to support the fact that washing hands is better. Because there was not enough good evidence. We published 2 important papers. The last one published the 8th of August a few weeks ago. I can send you the paper if you like. And we presented those results in those fora, where normally there are attendees from the Gates Foundation, from the other United Nations agency. As a matter of fact, Allegranzi, Benedetta, she's the responsible for IPC beyond emergency. And then there is April Baller, she's the responsible for IPC during emergency. And I work for April, but we work a lot together, April, Benedetta, and the other guys. And this was the only contribution which was invited to the last meeting of the G7. So this particular case was brought to the G7 attention because it's clear. I mean, for €1 you invest in campaign for teaching people to wash hands, you gain millions of euros in prevention. The point is that there was not enough evidence because research preferred to work on complex randomized trial and intervention and not on those effective things. In general. That's what we call infection prevention and control. That's the unit in the World Health Organization, which studies those figures. In Italy, you call it hygiene, we call it epidemiology, we call it, I mean, there are several things. What it is, the global name for that is infection prevention and control. I work for the infection prevention control unit of the emergency program. And this has been the unit which has been growing more during COVID. It's important for everything. During COVID, it's even more clear. Thank you. There was a question from the last row. No, no more questions? Come on, you have plenty of questions. You are just shy.
Thank you so much for your speech, Professor Pecchia. Can you ask you just mentioned the parallelism between ethics and risk management. Can you give more hints about this?
That's something on which we are working now. So the point is that ethics is important, is yet perceived as an abstract concept. Ethics is far from being an abstract concept, but also in application of ethics, you can follow very structured approaches. So there are things that you have to do in order to avoid any sort of risk, as we have seen in the CDC pyramid of risk management. And this is, you know, playing with human being whenever it is not needed, or using embryons to play football and stuff like that. That's clear, you have not to do that. But then there are other things where you need to intervene, you need to do, because there is a risk-benefit analysis you have to consider. So again, embryons, because I know this is a very complicated field and with a lot of divergent opinions. When we have embryons which have been come si dice fecondare in inglese? Prepared for the implants, but you cannot, my bioethicist Alessia, do you want to stand up so that she knows more than me on that? And they have been prepared for implant. And because of the Italian law, you can only implant a given number and you can do nothing else with the remaining embryon. Now, they are there, they will be frozen forever. We cannot use those for research. Now, this is an ethical dilemma, which I understand embryons is a sensitive topic, yet if they have to be there forever as ice cream, you know, probably if I was the embryo, I prefer you to use me for research, right? I'm not anymore an embryo, I know that, don't laugh on me. But it's clear that this is a risk-benefit analysis that we have to conduct. So there are things within which we have to act, even if they are more complicated, just avoid the mistakes. How this applies to this field in lower income countries? Well, we have seen several challenges. So again, donation of medical devices is still the main way for medical devices in many low-income countries, especially rural area in Africa. And they come with no clue of what they need, or they are not resilient, not designed, or you have a medical device which is safe and effective, if at all if it is used in a surgical theater where you have an equipotential node to avoid the risk of microshock. You know, many hospitals in Africa, they don't know what it is an equipotential node. So you need to be aware that the introduction of this medical device can be more risky than not. And this is an ethical dilemma, and you have to take an action. We have a couple of papers on that, on the filters for oxygen concentrators. It's a long story, but we find every time ethical dilemma when we work in emergency, lower income settings. Yet we need a guidance. You don't have a norm. I mean, the European regulation for medical device doesn't apply as it is to Africa or other lower income countries. Yet the underlying principles are correct, and that's ethics. So the underlying principles of regulatory science are coming from ethics. So we need to strengthen this and develop tools that you can refer to where you are in this dilemma. Another time I was in Africa, there was a machine for anesthesia, and it was broken. So the local technicians, they took two machines, they combined the spare parts. In the end, the machine was working, but the connector was not the right one. So they changed the connector behind, and now they could plug the wrong connector, the one for anesthesia gas, and use it for oxygen. It may look as a brilliant solution, but you have to think that once you are gone back home, next will come a team from Canada. They will never think that you inverted the tube behind and use the oxygen instead of anesthetic gas, and they will kill the patient. So there are a lot of things you have to consider. So getting a clear parameter of risk, a clear risk management approach into the ethical domain is crucial. So I have to do what I have to do now, yes, but without creating more damages than they have already, for instance. So I don't know if I answered your question, but hey, we have 7 days. You know. Yes, of course. 25 minutes. So I don't leave the stage.
Okay, so just a naive curiosity. I'm not an engineer. That's the premise. So about air ventilation for spaces like public transport or school classrooms, because it's an airborne disease, COVID-19, we know that very well. I wonder why wasn't this implemented on a large scale for public institutions especially? Is it because of the cost? I don't know, really. It's really a naive curiosity. Is it too costly, or it was not evaluated to be cost-effective measure? What is the reason why? Because for a common citizen, you know, it's airborne. Why don't we do anything about the air?
Because there are still concerns about the airborne transmission. We don't know if COVID transmits mainly through droplets or airborne. So with droplets, the transmission is much stronger than with aerosol, but aerosol stays in the room much longer than droplets. What we are trying to understand is the way in which COVID transmits through fomites. So the point of droplets is not that my droplet enters your mouth, it's very unlucky, but it's because your droplet ends up on my table, and then I touch the table, and then I touch my eyes. Now, in this case, it's much better to invest in hand hygienes or in PPE for faces rather than air ventilation, whatever, because this would not be sustainable. The other, it's easy and cheap. And we cannot be in the situation in which we think we are safe just because we have air conditioning. This has been the reaction for trains, airplane, which I appreciate, fine, 99.9% filtering, it's better than nothing. And where you are in an airplane or in a train, you can really get a good flux of water, so you don't have much retain. So probably there, the situation is correct. Yet, this is not all the problem, because the aerosol transmission of COVID, SARS-CoV-2 virus, is still questionable. We have several studies which are trying to put in comparison different kind of mask, FFP2 as the one you are wearing now, PPE mask, versus surgical mask, which are medical devices. And we got a lot of objections because people think that FFP are better. Truth is that we don't know, because you still don't know whether it's an airborne problem or an aerosol problem. Why you don't know? Because it is not easy to design a study really to prove that, because doing this study in real setting, it's difficult, because whatever you do, you are altering the setting. Doing this study in a BL3 lab, top of the gamma BL4, but BL3 is enough for COVID. It's impossible because you don't have enough sensitivity for assessing the quantity of virus which is still alive after aerosol transmission versus airborne. Airborne, I'm sure it will live, but airborne is mainly a problem for fomites, so not living object transmitting the virus. For instance, now we are converting COVID labs into monkeypox lab, because we need now to have this information for monkeypox. It is assumed that monkeypox is transmitted by sexual transmission. That's probably true in Europe, but not in Africa. So in Africa, the problem is still fomites and hygiene. And we are trying to design now a study to provide evidence on what it is the minimum percentage of bleach to clean or soap and stuff like that for hands washing, fomites, and surface. It sounds obvious, no? You put the virus and then you measure, and then if it works, well, otherwise not. In a BL3 lab, it's impossible to do that because, well, it's impossible. We are finding a way to do that, but we are spending 3 months to define the right protocol, because you have to dilute the virus, you have to dilute the agent, otherwise the agent will kill also the cell that you are contaminating. It's challenging. So you will live the Heisenberg paradox. So studying things in real life, it's complicated because you cannot bring in real life BL3 lab or just spread the virus in real life as if it was candy. But rebuilding real setting in a BL3 lab is impossible. We asked them, can you buy a washing machine, put in BL3 lab, and wash and then we see what happened with different concentration of soap. And they told us, yes, we can, but it will cost you 500,000 because then bringing this washing machine, which has been in a BL3 lab into Vasta, it's $500. So it's complicated. It's not so easy. So we still don't know enough about airborne and versus aerosol transmission, and this does not justify the investment in this direction more than what we have already done. Don't know if this was an answer. Yeah. Oh, sure. I don't read the chat, but if you can I read the chat? No, it's closed. Katie.
Yes, thanks. Yeah, thinking back to the risk assessment and weighing up the WHO recommendations like during COVID, do you think that there was sufficient, I don't know, analysis and understanding of the wider impact of things like universal masking and lockdowns, or do you think we've learned a lot in the past few years?
Oh, well, there was a lot of thinking about that. What is missing, was missing, is still missing. We are trying to do something there. Are models to try to balance the risk with, in this case, it's not a risk benefit, it's a cost benefit analysis there. And we lack good models in order to estimate the economic impact of those public health measures. So this is a huge problem. The majority of models we have are not enough sensitive to work on things which are very cheap. Again, for the washing hands model is a very good exemplar. So normally they are solved saying, okay, that's cost convenient because it's so cheap that you don't even give it a penny, you do it. For public measures such as lockdown and stuff like that, they tried, there have been several attempts, but what we know now after 2 years is that those models didn't work. But let me ask you a question. Do you think that no, that's a controversial question. I don't want to ask you this question. But the point is that we don't know. We don't know yet. And we lack fundamental health economic models to assess the impact of public measures in those circumstances. And then we didn't know if they've been lasting 3 years. And again, this could have been coming from the fact that we didn't enforce enough those measures in the start. So probably, you know, so there are plenty of questions, but that's why you need to work on that, guys, because there is now such a huge amount of information and open question that we need to answer and bridge as knowledge gap before the next will come, because it's just a matter of time. And again, I don't want to create anxiety where it is not needed, but we have entered the multi-pandemic era. So we are now working on COVID, monkeypox, and Ebola. There are 3 emergency of public concern open in this moment, which is an unprecedented number on a global scale. So it's be ready, study all the material we have from COVID and come with better solution than we found. Carmelo, back to you. And there was one remote which I'm reading now. Okay, Stefano Mingoni.
Thank you very much for the presentation. Nice presentation. Very quick question. You talked about lack of preparedness to combat the pandemic. I just want to know your thought. Who should really be blamed for that? I have seen at least one paper published well ahead. They try to predict this, like they call it time bomb. That was well ahead before the pandemic. So it sounds like the scientists have done their job. Then lack of preparedness, who should be blamed for that, you think?
Well, preparedness is not an easy domain because there are a lot of questionable perspectives, and it's every time a complicated field because how willing are people to wear masks in a train now? They feel the problem is over. The problem is not. We still are living the pandemic, and there are still tens, if not hundreds, of people dying every day for COVID in Italy. So there is a big problem here, and the way in which the NHS evolved, it's complicated because, for instance, you see the difference in Italy. So regions where the NHS has evolved towards private hospitals rather than public one, also called the trust, was very much worse than the one you get from regions where you don't have the same number of private hospitals. And that's because the NHS evolved in a different direction. So in places where there are not significant private components into the national healthcare system, there is a huge investment in prevention and public health as a general concern. And there is experience, so that you don't know yet what it is the next challenge, but at least you can use part of the previous experience to face it as a first reaction. I don't want to elude your question. So the target here is World Health Organization, giving the priority and probably the lesson learned. We are working on that now for COVID. And then the WHO is undergoing a huge period of transformation. So you will see in future years that regional offices will become more and more important because the concept of preparedness in Europe can be different than the concept of preparedness for Afro office or PAHO in the States or Asia or EMRO as a region. And then you need the national member states to react. The problem of preparedness is that during a public emergency of international concern or a pandemic, this is a binding act. If you're a member of United Nations, you have to react. But preparedness is for time of peace. And during time of peace, you don't have a legally binding act that you can enforce on member states. So it's left to the goodwill of member states. And normally they're not triggered towards this attention because we have to admit that the global discussion on innovation in this space is still driven by manufacturers. So you get, and that's one of the reasons why you saw my slide for medical ventilators, a lot changed in 100 of years, mask, nothing changed in 1,000 almost. And the point is that for medical devices, you have a very huge and developed medtech. They're making strange signs. I have to close, probably. Okay. So the point is that medical devices, there are big manufacturers investing. Masks, there are few. So this is not pushing the public agenda. And when it comes to preparedness, there is no one company which is investing on that. So it's all left towards the effort of the United Nations and public health. Okay, they're making strange sign, very polite but strange. So I suppose I have to close.
Yeah.
There was one question from the field, and it was Stefano saying, referring to the last concept, one about ethic. I think that ethic is not a good way to develop because I think that it changes in order to humankind needs. Yes, but humankind and their needs evolve over centuries, while if we just could add, good tools in order to behave in absence of guidance, regulatory frameworks for a few years, I think it would already be a great result. While human needs, normally they tend to evolve on a much longer scale. So I agree, working on ethics is just because we don't have any other solution. I'd love to enforce a global regulation on medical device. I cannot because there is not a global government. So ethics is better than nothing. If you have a better solution, please come out because I don't.
So thank you, Leandro. No more questions, so we're gonna have like a 45 minutes break.
45 minutes break.
So we will see at 4:30.
Hai detto 45 minuti di break. 40 minuti di break.